Thank you very much. And I would also like to thank especially Professor Liakopoulos for honoring me with the participation in this Congress. Thank you. The autosomal dominant polycystic kidney disease, ADPKD, is the most common monogenic cause of end-stage kidney disease. The identification of the PKD1 gene in 1995 and 1 year later the PKD2 gene facilitated the development of DNA sequence-based molecular diagnostics, and since then DNA molecular sequencing technologies have rapidly evolved and revolutionized the scene. Thus, ADPKD is a genetically heterogeneous disease with two culprit genes recognized. PKD1 is located in chromosome 16 in the long arm of this chromosome. It affects the majority of cases, approximately 80% of cases. It spans a large genomic region of approximately 50 kilobytes, and it produces a long mRNA transcript. It encodes polycystin-1, a transmembrane receptor, which its function still remains under investigation and has not been fully clarified. On the other hand, the PKD2 gene is located in the short arm of chromosome 4. It approximately affects 15% of families. It produces a smaller mRNA transcript, and it encodes a cation channel, which is polycystin-2, a transmembrane channel as well. The cytoplasmic tails of polycystin-1 and polycystin-2 interact and affect the function of the primary cilia, which in turn manifests with the clinical phenotype of PKD. The PKD1 mutation screening in specific has been rather challenging due to its large size, its high guanine cytosine content, but mostly due to its complexity. That is, the first 3/4 of the gene, that is the first 33 exons, are duplicated 6 times in 6 pseudogenes, which have a 98% DNA sequence identity with a normal gene. Thus, one can easily understand that molecular sequencing would yield high false positive and high false negative results. In case of false positive results, a mutation in the pseudogene might be recognized by molecular sequencing as a mutation in the normal gene, and on vice versa, a mutation in the normal gene might be missed due to the very high signal intensity of the pseudogenes. Genetic analysis of PKD2 is relatively easy. The gold standard technique, which of the sequencing of the PKD1 and PKD2 genes, has been developed by the Mayo Clinic research group. It involves a long-range PCR, which is, however, a technique rather labor-intensive and costly. So as to assess the problem of sequencing the PKD1 gene, 5 long-range PCRs are required so as to segregate the pseudogene from the real gene, and subsequently other 65 nested PCRs are required so as to sequence the whole normal PKD1 gene. The Sanger sequencing is more targeted. However, it also might lose approximately 4% of mutations due to large gene rearrangements. The next generation sequencing technology, the whole genome sequencing, the whole exome sequencing, and targeted enrichment technologies are expected to really revolutionize the field, not only in terms of time effectiveness and cost effectiveness, but they provide very high levels of accuracy, above 95%, reaching 98 to 100%. All the variants of mutations identified so far are recorded in the polycystic kidney disease Mayo database. So far, there have been recorded more than 2,300 PKD1 mutations and more than 250 PKD mutations. Mostly, the majority are germline mutations. However, a few, but there are continually identified new somatic mutations as well. In addition, apart from the mutation identified in the database, there are recorded the kind of the mutation as well as its potential clinical significance. I would like to point out that no single mutation accounts for more than 2% of cases, and there is a high degree of allelic heterogeneity. The genetic studies in ADPKD have provided significant epidemiologic information, have shed light on disease mechanisms, provide prognostic value, have broadened also the phenotypic spectrum of cystic kidney diseases, because we now know that not all cystic kidney diseases are due to PKD1 or PKD2 mutations, and they also aid us and have improved our diagnostic capabilities. The prevalence estimate of rare diseases can have important implications for drug development, with orphan diseases defined by a prevalence of less than 1 per 2,000, thus that one can understand in a rare disease it's not so easy to develop new drugs and to have investments for new drugs. Estimating the prevalence of ADPKD has been challenging in the population due to variable age-dependent penetrance and incomplete clinical ascertainment in the general population as well. Epidemiologic studies of clinically ascertained cases of ADPKD report a point prevalence of 2.4 to 9 per 10,000 population. However, new data now from the general population, which contain whole exome sequencing and whole genomic sequencing data in respective databases of diseased populations and normal populations, such as the GenoMAD and Bravo database, indicate a point prevalence of 1 per 1,000 regarding ADPKD in the general population now. Likewise, recent data from an observational study in Pennsylvania from a whole exome sequencing database, including approximately 170,000 patients, detected approximately 300 cases of ADPKD, thus suggesting a higher point prevalence, 1.7 per 1,000. Genetic studies in PKD have also informed us about the pathobiology of disease. Now we know that the germline mutation occurs in all cells. However, only 5% of kidney tubules exhibit cystic developments, and moreover, the cyst development in affected tubules is focal. This, together with the continuous identification of novel somatic mutations, have laid ground for the second hit hypothesis, in which the somatic mutation, as an add-on mutation to the germline mutation, leads to the threshold effect, that is, a lower activity than would be required for not developing the disease, that is, a cutoff of 20 to 30% activity of the polycystin proteins, and this leads to disease manifestations. However, novel data indicate another third hit model for disease pathogenesis, that is, add-on gene mutations in other proteins of the endoplasmic reticulum, which are involved in the processing and trafficking of polycystin during protein biogenesis. Finally, all this together leads to the snowball effect, where histopathologic changes such as tubular obstruction, inflammation, regional ischemia, and metabolic reprogramming beget more disease manifestations, more damage. Knowing the mutation class also helps us to predict disease severity and disease variability. Thus, we know that protein-truncating PKD1 mutations are the most severe mutation and associated with end-stage kidney disease approximately at the 5th to 6th decade of life. On the other hand, there is an intermediate phenotype of non-truncating PKD1 mutations, where end-stage kidney disease occurs approximately 12 years later. And finally, the most benign phenotype are the PKD2 mutations, where 8th-stage kidney disease occurs in the 8th decade of life, approximately. And also from large genetic studies, we know that these patients also have a lower height-adjusted total kidney volume as compared to PKD1 mutation patients, as well as a higher eGFR, as well as lower number of cysts. All these are adverse prognostic factors in terms of kidney function loss. The researchers from France, which have provided us large genetic studies regarding ADPKD, they include a high-risk cohort, the Jenkins cohort, which continuously to be under study. They have developed a risk stratification score, which includes 3 clinical variables, that is, gender, occurrence of hypertension prior to the age of 35 years, and occurrence of a neurological event prior to the age of 35 years, together with an the type of the genetic mutation, so as to provide a prognostic classification. The patients are categorized in 3 groups: in the low, intermediate risk, and high risk groups. Those who collect less than 3 points are expected not to reach end-stage kidney disease by the age of 60 years with a negative predictive value of 80%. Those who acquire more than 6 points in this classification are expected to reach end-stage kidney disease by age 60 years with a 90% positive predictive value. However, it should be pointed out that the utility of the score and of the genetic score in particular is extremely important in patients, in younger patients, for example, those less than 35 years, who have not yet developed any clinical event, such as hypertension or an urological event. Thus, in these patients, the utilization of the genetic score, knowing the type of mutation, non-truncating, truncating, or PKD2 mutation, would be extremely helpful. In addition, as I previously mentioned, there are other genetic causes of polycystic kidney disease beyond PKD1 and PKD2. It appears that specific mutations in the sarcoplasmic reticulum proteins, GANAB, GB11, LG9, are associated with a cystic kidney disease phenotype. However, development of kidney dysfunction is rather variable and mostly associated with a mild phenotype with respect to the kidneys. However, these patients also develop cystic liver disease. Thus, it is suggested that it is one spectrum. On one hand, this is one spectrum of autosomal dominant polycystic kidney disease in the one end of the spectrum, and the other is the AD polycystic liver disease. With regard to our clinical practice, scenarios where genetic testing is clinically indicated involve three major cases: when suspected ADPKD but no apparent family history; there is suspected ADPKD but with equivocal kidney imaging findings; and when we want to exclude ADPKD in young, for example, less than 25-year-old at-risk subjects, when they are considered either for living-related kidney donation, when they want to obtain life or disability insurance, or in cases of prenatal or preimplantation genetic diagnosis. In everyday clinical practice, the diagnosis of ADPKD relies mainly on a positive family history, plus validated age-dependent diagnostic criteria, mainly ultrasound-based, but in equivocal cases, MRI is extremely helpful. However, there is no apparent family history in up to 28% of patients suspected to have ADPKD. This might be due to an availability of parental medical records, mild PKD unrecognized in affected patient, genetic and non-genetic renal cystic causes of renal cystic diseases, de novo disease, and the presence of mosaicism. On the other hand, atypical kidney imaging is present in up to 16% of patients suspected to have ADPKD, as manifested by the Mayo classification type 2 regarding kidney imaging in PKD. This might be due to non-truncating PKD1 or PKD2 mutations, which are associated with a mild phenotype, or there would be the case of a second kidney disease in patients with moderate to advanced CKD but mild cystic disease without kidney enlargement. And finally, again, the case of somatic mosaicism. Mosaicism refers to the presence of two genetically distinct cells population within one individual, resulting from a somatic mutation during embryogenesis. Mosaicism in ADPKD refers to approximately 1% of a typical ADPKD population, but in case of unresolved PKD cases with no gene identified, it approximately, that is the case in 10% of these patients. However, to detect mosaicism is rather challenging by molecular sequencing because of a low signal-to-noise ratio, mutation signal-to-noise ratio. Novel barcoding techniques of the DNA targeting specific cell populations like epithelial cells of the buccal mucosa, the urogenital tract, might lower the threshold and identify mosaic cells with a cutoff of approximately 2%. Preimplantation genetic diagnosis involves the extraction, the amplification, and analysis of DNA removed from the blastomere or the trophoectoderm of embryos creating using AVF. We know that affectual individuals with ADPKD have a 50% chance of passing the mutation to each of their offspring. Assisted reproductive technology using preimplantation genetic diagnosis allows individuals with PKD to reduce this risk to 1 to 2%. Thus, preimplantation genetic diagnosis should be offered to all families, all ADPKD identified families who wish to have children. However, their response and their acceptance depends on different parameters, mainly social, ethical, economic, etc. In a relatively recent study regarding the acceptability of patients for preimplantation genetic diagnosis, the authors found out that the patients are rather negative to prenatal diagnosis and early termination of pregnancy. Approximately 70% of patients would say no to prenatal diagnosis and end of pregnancy. However, if you offer preimplantation genetic diagnosis, so this would not lead to termination of pregnancy, their attitude is completely different and their acceptance rates reach 60 to 70%. However, as I previously said, the new techniques, which will be cost and time effective, are going to expand the scenarios and new indications will be set for genetic testing in ADPKD, such as the case of delineating the cause of atypical clinical presentation, early and severe disease, when we have marked intrafamilial discordance, syndromic forms of PKD, and finally, to identify novel medications so as to treat these patients. Severe PKD with marked bilateral kidney enlargement and end-stage CKD established during early childhood or adolescence usually is due to either compound heterozygosity, like one protein truncating PKD1 mutation in trans with a second non-truncating PKD1 mutation, digenic disease, for example, one PKD mutation together with a second mutation in the PKD2 gene. However, biallelism or fully inactivating PKD1 or PKD2 mutations are not compatible in life and in utero. Also, identifications of families with bilineal ADPKD has important implications for genetic counseling. Bilineal disease, that is disease from the two parents, is predicted to occur very rarely in the general population and might be missed because one of the parents has only the mild phenotype of the disease. A high index of suspicion is required, and when in large pedigrees, we see that in this case, we might see that 75% of the children might be involved rather than the expected 50% in these cases. Extreme kidney disease discordance is present in at least 12% of families with ADPKD, regardless of the underlying mutated gene or mutation class. This marked intrafamilial variability, either in terms of total kidney volume or GFR adjusted for age, would lead us to suspect either the presence of unusual genetic environment, such as somatic mosaicism, digenic disease, or we should consider the presence of another kidney disease not related to genetic causes, such as diabetes, glomerulonephritis, as well as comorbidities such as hypertension and obesity. Genetic studies also have brought into attention other causes of cystic kidney disease, such as syndromic kidney disease. The tuberous sclerosis gene is adjacent to the PKD1 gene, and there are cases of a continuous deletion of both genes, leading to severe kidney cyst early in childhood and stage kidney disease early in childhood, together with the tuberous sclerosis phenotype. Another example is the von Hippel-Lindau disease. I would like also to mention the spectrum of the AD, autosomal dominant tubointerstitial kidney diseases, which are gaining increasing attention. They are associated with mild cystic phenotype, variable renal function, but the presence of other traits, such as the presence of MODY or the presence of hyperuricemia and gout with relation to the specific gene mutations, such as hepatonuclear factor 1b or uromodulin, respectively, lead us to suspect that we are not dealing with ADPKD, but another cystic disease with genetic basis. And finally, genetic studies are required for drug repurposing in AD-PKD. The novel, as Dr. Foundoglou previously referred to, GWAS studies, transcription and gene profiling, investigation of the genomic data, and integrating GWAS with the omics data set might assist to identify compounds for drug repurposing available drugs and to be repurposed in ID-PKD. And finally, a few words regarding the patient perspective. There are questions that when we offer genetic testing, there are questions that we must answer to the patient. What will I do with information once I have it? Will it prevent me from obtaining medical or life insurance? Am I better off knowing or not knowing? And can I financially afford the test? So, the pros of genetic testing is that we might offer the patient lifestyle and medication intervention, advice regarding family planning and living donation, and increased knowledge about AD-PKD. On the other hand, we must ensure legal protection, insurance, and emotional support for these patients. Thank you very much.